Thank you very much. So it's my pleasure to invite Dr. Sujit Jha, who heads the Department of Endocrinology at Max Super Specialty Hospital. And as we know, diabetes is a very common problem. One of the most common complications that we face is to walk a fine line between controlling the blood sugar very well and not have the patient's blood sugar level drop too low, because hypoglycemia can be a dangerous thing. And so without further ado, Sujit.
Dr. Jha. Dr. Jha. Dr. Jha. क्या उसको बोला था जाने के लिए? Anyway, I'll just start while it's being loaded up. Thanks, Anu. Thank you. Thanks, Dr. Agrawal, for inviting me there. I think it's very interesting, I must say, and we all are responsible for it. Dr. Jha, responsible for it. I think most of our lectures in diabetes, and I think I do 100 lectures in the last 2 years, 99 is on hyperglycemia. And I think, thanks, Dr. Agrawal, for giving the opportunity of talking about hypoglycemia. And I keep saying to the hospital when, everybody refers to patient that, Dr. Jha, blood sugar control kar do, fine, that I always say there are two customers. One is my clinicians, the other is patients. And I tell them that if you ask me that no hypoglycemia, send me to Hardwar. I can't practice medicine without creating hypoglycemia. I must say it's not intentional, but it's impossible not to create hyperglycemia, especially the blood sugar. And thankfully, the blood sugar targets have changed in the recent worlds. We're not targeting 110 these days. We are targeting 140 to most patients to 180. So what I'm saying to say that in the teaching centers in the US, 7% of the cases are hypoglycemia. And this 7% comes on 2 documented hypoglycemia of more than 60 below. So what I'm saying that hypoglycemia would happen, will happen. I don't see any feature of how we can prevent hypoglycemia. The more insulin, let it oral insulin comes in, whatever comes in, hypoglycemia would happen in inpatient setting. In an outpatient setting, it's carrying on happening. And in our country, I'm sure it's a famous dialogue that, where the pizzas can reach within 30 minutes, but the ambulance can't reach 30 minutes. I can tell you that one incident which happened a year ago, that one of my patients was driving in one of the horrible monsoon season, right at the top of the Mulchan Hospital flyover. And he called his father, like, I think I'm having hypoglycemia and get me some sugar. And he literally collapsed. So I'm taking it further, sleep apnea and hypoglycemia. He literally collapsed. His next door driver, the traffic was stuck for 3-4 hours. If you remember 3 years ago, the huge traffic. And somehow that gentleman gave him chocolates and he woke up. And his father, who was around 68 from Gurgaon, went to the motorbike trying to trace back where he is, because we don't have ambulance service. So the hospital down below on that overbridge was Mulchand. So we in a country, unfortunately, sad, we can't create this ambulance crew to reach the guy who has hypoglycemia. So in our country, hypoglycemia education is so important, where you can be five minutes driving away from that distance of the hospital, where we don't know what to do about it. So, and it's very frustrating. I keep saying that. I'll highlight that because and I must say that I keep saying it to my patients, and every prescription, please show me one prescription which I have not documented and educated about that hypoglycemia to explain to the patient. And I always say that I need to save my back first, then patients. So must educate about hypoglycemia to the patient, A. B, and must document it as a doctor. So you have chance to exit, because it's going to be a little boring here. So if you are busy, day, this is what I got the opportunity to photograph myself. I think, I don't know, you had a chance to go? It's just outside Washington, D.C., the studio, that you can pose yourself, as the president of U.S. And what is hypoglycemia? Most of you know about it. It's the blood sugar goes abnormally low, And blood sugar, you can call it different guidelines, but I call it below 70, mainly because in our country. But if you convert it to millimoles, it comes to below 2.5. But I would call it 70 because awareness in our country is very, very poor. How to treat, we don't know. So I would call it below 70 as hypoglycemia, and that's why the our Max Hospital hypoglycemia protocol is also based on 70. And there are, I just want to emphasis, I think, more stress in on hyperglycemia secondary to diabetes, because hyperglycemia per se is a separate topic, but I'll just try to cover a little bit. So most common is insulin, alcohol, sulfonylurea. It's very common to cause hyperglycemia. The non-drug induced hyperglycemia can happen. The suspicions of hyperglycemia fasting insulinoma should be low. It's a rare disease. You need to be really careful, yes, but I'm not saying that you can't miss it. But sometimes we do suspect large patients who are not on drugs, blood sugar feels like hyperglycemia, and we start suspecting insulinoma. Yes, we should suspect it, but why we, to rule out insulinoma is not easy task. So it's a tight control, you need to control. We know that good sugar control, as Prof. Mittal highlighted earlier, diabetes is moving forward, thankfully, and we have different way of treating diabetes. But it's a tight rope that you can end up in hyperglycemia, and the more, this is the take-home message. If you get your HbA1c lower, which we try to get it, you create more hyperglycemia. So you can have hyperglycemia. If a lot of my patients comes in with HbA1c is 5.5, I'm not happy, especially relatively older people, because they must be having some sort of hyperglycemia. You can see that HbA1c of 5.5, 100 patients per year can have hyperglycemia. So a large number of patients can have hyperglycemia. If they're on sulfonylureas like glyburide, glycoside, insulin, you must think patient almost you'll have to say that you have hyperglycemia. The other thing is that, when the patient say, Doctor Sahab, blood sugar मेरा पर control हो गया है, insulin requirement कम हो रही है, I'm worried. Because there's something happening here that it might be crazy. Insulin requirement doesn't go down. I'm worried because patient might have renal failure because of diabetes, and that might be increasing risk of hyperglycemia. So you need to be really careful, clinicians, and this is one of the photographs. So the most important is safety, and this was one of the things which, I love about Americans, you buckle up, which, put your belts on because Sheraton loves you. I think same thing, we must important emphasize that, while treating diabetes, you must warn about hyperglycemia. And it's a very tight rope, and you can fall this way. So when you are targeting blood sugar of something between 80 and 90, and especially in a gestational diabetes where the fasting we sometimes target 70, you can fall over the other side. It's a, pre-lunch, little complex side, but I can tell you that type 1 diabetes, hyperglycemia, unawareness is common. Means blood sugar can call 40 to these young kids, and they can sleep over, and that can be damaging to the brain, especially for next day school learning. So hyperglycemic unawareness, which people are not aware, which is the God-gifted mechanism that if you give me 4 units of insulin IV, I would get hyperglycemia, and I would respond, and I will look for hunger, I will have palpitation, I will have sweating, I will have discomfort. But some people may not have hyperglycemia, so that's not good, mainly because the sympathetic drive is affected. The epinephrine drive is affected through in type 1 diabetes. The hepatic glucose output, which is required through glucagon synthesis, is also affected. So very important, unaware people, yes, you should be more careful about it. But type 2, usually awareness is still intact because the whole cycle of sympathetic drive and the glucagon response is there. And I'm not going to go into details of this. So symptoms, I'm sure all of you know about it, and you all must know about it, and all relatives should know about it. The whole country should know about it because there are 10 crore people with diabetes, and I think technically a large number will be on sulfonylurea. So the whole country should know about it. If somebody starts sweating, trembling, it may not be heart disease, because patients of diabetes have a risk of heart disease. You must treat them with hyperglycemia. And these are the symptoms. Severe hyperglycemia, patients requiring third-party intervention. So if I fall there with hyperglycemia and I can't eat any glucose tablet, I'll come back to glucose tablets later, then you have a severe hyperglycemia and the third party is required. Unfortunately, in our country, we can have everything in the world, but we don't have glucagon available, which is a basic treatment. And the plasma glucose falls below 70. Documented, severe hyperglycemia, you don't have to document the blood sugar. In a documented hyperglycemia, where the blood sugar has been documented to have blood sugar below 70. So asymptomatic, when the patients have blood sugar less than 70 and they don't have symptoms, and that's very dangerous. Probable symptomatic hypoglycemia, where you have suspicions, patients say, look, pre-lunch, very common, especially with sulfonylurea, the blood sugar starts falling below 70, and they treat something with hypoglycemia, that's good, but yes, we call it probable symptomatic hypoglycemia. This word I would like to talk about. How much time I've got? How much time? Okay. Okay. Sorry? Okay, I'll just try to, 5 minutes more I think I need. So I just want to emphasize the relative hypoglycemia. If you start patient with a blood sugar of 400, start treating with even metformin, blood sugar goes to 200, they feel low. Must warn them. They can eat something because they have adjusted with a high blood sugar level. It's a very common problem. So most people newly diagnosed diabetes, and if you load them with sulfonylurea and insulin, they can have blood sugar running at 200. They'll say, "Mujhe to hypo ho rahi hai." Yes, they're true, but they're relative hypoglycemia. Patient is not going to die of hypoglycemia, but they can have hypoglycemia. So it's very important to warn them, and it's very important to bring the sugar in a graded fashion, rather than jumping over them and trying to bring sugar to 100 if they're running on 400. It's a very common problem. So trust patient. If the patient says, "Doctor, blood sugar 200 hai and I'm feeling low," might be because they are used to high blood sugars. It's not that they're saying it's wrong. So there are different reasons of hyperglycemia, and as suggesting alcohol, hepatic, renal, and cardiac failure, any organ failure can cause hyperglycemia. I think in renal failure, in dialysis unit, very common. Patient non-diabetic have hyperglycemia. So when the patient walks in, anybody on insulin, they say, "Look, my insulin requirement is going down, and my blood sugar to dawa ke theek ho gayi." That's not right. It means there's something wrong with the patient. You must rule out why his insulin requirement has gone down. Until unless he has changed his diet, lifestyle, that's fine. But if it's not, you must check the kidney function test because they are very high risk of renal failure. Some infections going on, something else going on, some other drugs happening. So don't take it easy. Take it seriously if somebody says insulin requirement has gone down. Cortisol deficiency. If you have type 1 diabetes, I know if you're treating type 1, you must rule out hypercortisolism as well. You must, and the other list is there, huge, extensive. But the common things are common. Sepsis, infection, renal failure must be ruled out. There are several drugs, and I must say that I'm proud to say that the third drug has been documented by my father in a 1976 publications to call diabetes as well. And the pentamidine, he has also documented that in a transaction, Royal Transactions UK, that pentamidine causes hyperglycemia. And during treatment, pentamidine used to be treatment for leishmaniasis. And pentamidine used to be causing hyperglycemia. But though we don't use it, I think most of you may not have experience. But those who have worked in Bihar might have used the pentamidine for Kalazar. Gatafloxacin, I think, has been banned in India. And I was reading what is this simenzolin, which is a new class 1A anti-arrhythmic drugs like dipyridamole. It has got less anticholinergic activity. I am not sure it's available in India, but that can cause indomethacin, quinine, artesunate, which I think lithium you use it. But these are the drugs, or any quinirons group, norfloxacin, ciprofloxacin, sometimes even ACE inhibitors can precipitate hyperglycemia, ramipril or lesinopril. But these are the drugs. So common drugs are norfloxacin, quinine drugs can precipitate hyperglycemia even in a non-diabetic, but definitely in diabetes patients. Heparin can cause it as well, So just, you have to really remember ACE inhibitors and ARBs can cause hyperglycemia. Oral drugs, right on the top, insulin, but I must say that you must warn them, especially if they are on insulin sulfonylurea. But the rest of the drugs, GLP analogs, alpha-glucosidase, they're not prone to have that hyperglycemia. In addition, if they are on sulfonylureas, yes, they can. But if I give metformin to the whole belly, I would expect that hardly 2 or 5 patients would come into hyperglycemia. So it's not that common because we give to PCODs, even thin PCODs. So it's very important to understand what you're treating. But they are on gliclazide, glimepiride, they can have hyperglycemia. Causes of hyperglycemia, I think I've briefly already discussed. I'm not going to go. I think most of you know lack of education, exercise, late meal, renal failure, sick, any flu, anything happening. We call it sick day rule. They can have hyperglycemia. I'm just going to skip this, and I think I'll just one slide. A lot of you patients see fasting 90, post-prandial after 75-gram glucose challenge going to 70. What do you do with that patient? That's a common. If they have no symptoms, don't do anything. Because it's not easy in a normal life setting to have 75-gram glucose. So if there are no symptoms, it's common to have it. And I'm not going to go into details of it, but it can fall. Earlier, we used to say that it could be because of higher insulin resistance, but it can fall. It's common. We call it post-prandial functional hyperglycemia. If they are symptomatic, tell them to have high fibrous diet. Because eating 75 glucose, even somebody like me who loves jalebi, is not that easy. It takes time. it's a really hard quantity of large quantity of 75 gram jalebi, you have to eat it to cause that, 75 gram glucose. If they have it, the blood sugar can fall down and they can have symptoms, then you're worried about it. If there are large symptoms, some people can have headache, mental dullness after meals. And you check their 100 gram glucose, blood sugar falls to 50, 60. Sometimes you can treat them with metformin. I can discuss later why. Or alpha glucosidase like acarbose and voclibose, you can prevent them. So this is about insulinoma, and that's why I'm saying, if somebody getting fasting blood sugar, documented lab glucose, mind it, lab glucose, don't just go by glucometer. If they have been documented below 70, yes, I think you have to rule out insulinoma. The only way of ruling out insulinoma is by 72 hours fasting glucose. Don't just do the C-peptide until the blood sugar has fallen below 50 in a normal setting, and which I would not advise to the patients. You have to do a diagnostic test, which is 72 hours fasting. Treatment, easy. This is one of the publications which we did in EASD in Lisbon, where we reduced the number of hypoglycemic incidents in our hospital by following a simple hypoglycemic protocol. I'm quite happy to share with it how to respond to hypoglycemia, nurse-led. You don't need to call. So my patient's hypoglycemic, now in the hospital, Max Hospital, they're going to call me, and I'm going to say what treatment to be given. That's absolutely wrong. It should be nurse-led, nurse-driven. We can't wait for hypoglycemia for doctors to act, even floor doctors. So it's a severe treatment. This is not available in the country easily. Glucagon. I don't know why. I tell you, we can send rockets to the space, but we don't have glucagon. I have difficulty in getting glucagon to our patients. Glucagon is a standard treatment. If it's not available in the country, doesn't mean that we should not use it. If it's not been used in our country, it doesn't mean it's a very high stuff treatment. I get calls from the pharmacy, sorry to say that, what the hell I'm using for it. It's a standard treatment. If you're using car, and if you don't have car, you say, what the hell this car is all about? It's not about that question. It must be used if you have it. But unfortunately, it's not easily available. Hypoglycemic treatment, mild, moderate, severe. You must check, if it's mild to moderate, give them glucose, check blood sugar in 15 minutes time. And the standard treatment, if you look to any websites, ADA or go to Diabetes UK, Australia, UK, says glucose tablets. Do we have glucose tablets in our country? We don't have it. Thankfully, one of the industry just shown that in the front here, they have the glucose tablet. We do not have glucose tablet in our country 2012, 22nd of January. I don't know why. And it's not the responsibility of the industry. I think we should force the insulin companies to produce glucose tablet. If they want to carry on producing, we export to the rest of the world about insulin, but we can't manufacture a glucose tablet in our country. Very sad. So we can send it, but we don't have glucose tablet. It's just $4 in supermarket. One of my patients who is getting hypoglycemia after bariatric surgery is a nurse, and she has sent me around 200 boxes of glucose tablet, which I give it to school kids to prevent the hypoglycemia in the school. And I think last box was just dispensed yesterday. So we have 200 boxes. And I keep telling my patients who goes to, outside the country to buy it from the Boots pharmacy or any pharmacy, it's a $4, 40 tablets pack. So you must have.
Dr. Sujit, please.
Yeah. So one of the things is even dogs can start smelling hypoglycemia. In the UK, they have started training dogs. If the patient odd behavior, they have been trained to cause hypoglycemia, so they can pick up. It started working, interestingly. So if we can train dogs, I'm sure we can train humans and create the hypoglycemia. We should be aware of hypoglycemia. Standard treatment, glucose tablet. If patient can't respond, glucagon injection. If we don't have a glucose tablet, take sugar, because sugar will take 10 times glucose. But sugar is important, education is important, must document on the notes and tell your patients that you might have hypoglycemia, more in the hospital setting. We cannot work without hypoglycemia. It would happen, but we must act swiftly, quickly, and buy glucose tablets or buy sugar, whatever available, but we must treat it. Thank you very much. Thanks a lot.